So, good afternoon and a warm welcome to all the dignitaries present here. I'm Sreyushi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat, and the focus of today's session is Craig's presentation on neonatal sepsis. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Kindly proceed with your talk, sir. Over to you.
Thank you so much, Shriyasi. So today we are continuing with our neonatal Pathshala. Today we are going to take a case presentation. So for that we have Dr. Viraj with us. And to mentor this session, I would invite Dr. Urvi Sanghvi. And with that also we have an expert, Dr. Somsekhar Nimbalkar sir. Unfortunately, today Shwetal ma'am is not able to join. So I would request Dr. Urvi Sanghvi to continue with introduction, and then Doctor for the case, I would request Dr. Viraj. Over to you, Dr. Urvi.
Yeah. Thank you, Dr. Kunal. Good afternoon, all. Welcome on behalf of NNF Gujarat. Today's our topic is a case presentation on neonatal sepsis. It will be presented by Dr. Viraj Jain. She is a pediatrician from KD Hospital, Ahmedabad. Today, her mentor is Dr. Snehal Patel. She is an assistant professor at KD Hospital, Ahmedabad. And our expert today is Professor Somsekhar Nimbalkar, sir. I think everyone in world and internationally, everyone knows, sir. But just to brief his CV, I would say sir is professor and head of Department of Neonatology at Baikal University. Sir is editor-in-chief of Journal of Neonatology NNF, Joint Secretary KMC Foundation. Sir is chairperson of IAP Medical Education Chapter. Sir is member of expert group of ILCOR. Sir is first to lead the program of DM Neonatology in Gujarat since 2021. Sir has published and is also ongoing research nationally, internationally. Is a long list. So I just welcome Sir and ask for his expert opinions and for the presentation of the case. Over to you, Dr. Viraj. You can start, and welcome, Sir, again.
Thank you very much.
Am I audible?
Yes,
yes.
You can start sharing the.
Good afternoon, everyone. Thank you, Neonatal Pathshala, for giving me this platform. I'll start with my presentation.
Please make it full.
Yes, sir.
Perfect.
So I'm presenting a case, a baby of XYZ, born to a 25-year-old mother on Jan 30th. Date of admission was 17th Feb, and the baby came to us on 18th day of life, was a female child, was mother born to a primi gravida mother, full-term singleton pregnancy, normal vaginal delivery at Government Hospital, Abo. The birth weight was 2.5 kg, and Apgar score and resuscitation details were not available. Antenatal history was not significant as informed by the mother. We don't had any documents. Postnatal history, the baby cried immediately after birth, 2.5 kg normal vaginal delivery, was shifted to mother's side and was given exclusively breastfeed, was discharged on second day of life. Birth vaccination was given as history given by the parents. At third day of life, the child had neonatal jaundice and weight loss, so was admitted for phototherapy for 48 hours. Documents were not available. So post-discharge, the mother noticed decreased activity, decreased feed, and low-grade fever in the child. Next day, parents noticed swelling over the right chest wall, which was increasing in size associated with pain and decreased limb movement. There was no history of trauma, massage, swelling at any other site. For the above complaints, the parents got the baby admitted to a private hospital at Abu on 8th day of life, where the baby was investigated and managed for the same, and where the baby developed some breathing difficulty, so was put on oxygen support. They took Dama and came to our hospital on 18th day of life. On admission.
Can you go back a little bit?
Sorry, sir.
Slide. Can you go back a little bit, one slide?
Yes, sir.
So far as I understand, baby has never been well.
Yes.
Because he got admitted for jaundice on day 3, and then in the hospital, they noticed a swelling in the right chest. Is that correct?
Yes, sir.
Or after discharge? So,
Yes.
so got admitted and got discharged on day 5, and then went back on day 8. Same hospital or different hospital?
Sorry, sir.
Day 3 पे वो admit हुआ था, correct?
Yes, sir. The child was admitted on day 3, and for 48 hours they kept the child for phototherapy. We don't have any documents available for the same. After that, on the very second day, the mother noticed decreased activity and decreased feeding and fever. And after this next day, the parents noticed a swelling which was developing over the right chest wall.
And the baby got admitted again to the same hospital. Is that correct? Or is that
no, sir.
not?
They took the child to a private hospital.
It was a government hospital and then the private.
Yes, sir.
So oxygen support, does it mean CPAP, ventilation, or just plain oxygen?
Sir, oxygen was in the form of O2 by prongs in the private hospital.
Okay. All right. Please go to the next.
Yes. So on admission, general examination, generalized edema was seen. There was dull ash and gray look, septic look, severe pallor was present, swelling over both shoulders, mild swelling over right thigh. There was decreased movement of right upper limb. Vitals were measured on the very first day. High-grade fever was there, 103. Tachycardia, 270 per minute. SATs were maintained on oxygen by nasal prongs at 2 liters per minute. The peripheries were warm, but there was altered perfusion in the form of CRT was more than 3 seconds. Hypotension was there. Blood pressure was 56 by 20. Random blood sugar was normal. The weight was not recorded on day 1. The day 2, it was 2.305, and the birth weight was 2.5 kg.
Based on this criteria, okay, we can look at the system again. We can look at this next slide.
Okay,
please go ahead.
Systemic examination. There was tachypnea, bilateral air entry was present and equal, subcostal and intercostal retractions were present. Tachycardia was seen, increased CRT was seen. For abdomen, there was gross distension, visible veins were present, and it was tense. The child was irritable, cry and activity were dull.
So based on based on your clinical examination, systemic, what do you think is the status of the baby? What might be the things that you expect?
So based on the general examination and the systemic examination, the child was having multi-system involvement in the form of the look was very dull and septic. So it was probably because of sepsis. There was tachycardia, high-grade fevers, and also there was respiratory distress. And the perfusion was also impaired. So the child was probably in septic shock. Also, there was a swelling which was seen over the shoulders and mild swelling over right thigh with generalized edema. So the child was basically septic, and their swelling could have been the reason for the same.
So any details on swelling, whether it was painful, size of swelling, and whether there were color change on the skin? Any details on the swellings?
The swelling had some redness.
So it could be multiple abscesses in the joints, eyes, so that.
Yes, sir.
Thinking about that. So were there abscesses, or can we have more information on the swellings?
Yes, sir. This swelling had redness over it, and on examination, the child was not allowing to touch, and it was very irritable. So there was associated with pain as well. There was decreased movement of the right-sided upper limbs. So on the right side, there was probably an abscess. It could have been possible.
Now your CRT is more than 3 seconds. Would you rely on CRT or would you not rely?
Sorry, sir, I didn't.
Your capillary refill time is more than 3 seconds.
Yes,
Would
sir.
you rely on it good indicator, or is it a bad indicator in this particular?
We can rely on it because of the hypotension as well associated with it. And with sepsis, there is a possibility of septic shock. So if the CRT is prolonged, then we should definitely do immediate management for the same.
Two things where CRT is not reliable is when there is fever in the baby, and second, when there is the environment is cold, so where you can't rely on it. So it is it's something which you will take, of course, you'll record it, but it is not a reliable indicator. Please go to the next slide. Yeah, so you have not mentioned in the systemic examination what is the respiratory rate. I did not think respiratory rate mentioned. You read it, yeah. So
yes, sir. The respiratory rate was around 65.
65. So when the temperature of a baby is 103, 65, and with the saturation of 98% on 2 liter oxygen, it looks to me that the lungs cannot really be affected, but there's something else here. Subpostal retraction and interpostal retractions. How bad were the retractions?
Sir, very subpostal retractions was very deep. Intercostal retractions were mild.
Okay. So does it give any idea what it indicates? More retraction, what do they indicate as far as lungs are concerned?
Sir, it involves underlying lung pathology as well if intercostal retractions are there.
Okay. So what lung pathology would you expect?
There could be pneumonia in the child.
So that is the indication that the compliance is poor, and hence you're getting your intercostal retractions. So Dr. Vishal has asked, what is the Downey score? Did you have a Downey score, or Dr. Vishal, we should call it as Downey Vidyasagar score? So because people tend to forget people. Vidyasagar was a professor of Dr. Downey. Both of them did. So do you have a Downey Vidyasagar score?
We do Silverman Anderson score in the babies at first, our unit, in our unit.
So what was it?
The Silverman Anderson score was 6, sir.
Okay. So, right. The abdomen is distended, there is gross distension, visible veins. Or do you have abdominal girth that was recorded?
No, sir, we don't have that. We could not measure that at times.
What might be the reason for distension of the abdomen?
Sir, the child was edematous. Also, on examination, it was looking like a gaseous distension also. So there could be abdominal wall edema with gaseous distension, or there could be underlying ascites in the child.
So why would there be this gaseous distension? Why would it be gaseous distension?
Sir, because of sepsis, probably there would be ischemia of the mesentery and the intestines, which would lead to impaired peristalsis, and that would lead to retention and gaseous distension.
So ileus would be reason. So ileus secondary.
Yes, sir.
Okay, so what is your current diagnosis of this particular stage? Findings, yeah.
On the basis of examination, sir, as history and examination, the child is a case of severe sepsis with septic shock, probably secondary to underlying swelling, which could be an abscess.
So, multiple abscesses. What might be the reason for multiple abscesses?
Multiple abscess could be secondary to severe septicemia first.
So this patient is 2.5 kg, nothing very interesting in the delivery details. And then subsequently, patient has had sepsis and with multiple. So I would you think this would happen in any normal term baby? Because this is like a normal term baby, nothing very important. Then we find baby who's pale, septic, with multiple abscesses. Because I don't have any idea of the case, and you have seen the case. It's been there for 2 months.
So there was
what
an history. There was a history on day of life 3 that the baby was admitted on day of life 3 for neonatal jaundice, so at a government hospital. So it could be due to some hospital acquired infection as well. We don't have the details for the same, so we don't know what intervention or any reports were done or not. Any IV line was inserted or.
Okay. Unlikely. So, so there's a question in the chat from Dr. Urvi. Was some intervention done for the therapy? You have any question like that? You have any information? I wouldn't think that would. I think this might be something some inborn error or something like that, which might predispose the child to infections, and that is causing particular. Even if we only get babies because of sepsis, because of hospital acquired infections, we generally wouldn't get widespread sepsis and this within a short period of time. So it's really very likely. Why has what happened? Dr. Viraj has left.
Yeah, I think by mistake she would have left.
Yeah. We wait for her to join. Interesting case. So I think abscesses, osteomyelitis, canicrosimia can be there. So we have some inborn errors, maybe not a CDC, but maybe not the
Something like SCID or very rare.
બીજો ફોન ક્યાં છે?
Dr. Snail, you have an idea what has happened?
Sir, just a fact, sir. I'm sorry. There is some connection problem and I'm fixing it up. Yes, sir.
Okay.
Tell me, what is your question, sir?
No. She has got disconnected. So you are in the same area, or she's presenting from somewhere else?
Yes, sir. I'm in the same area, sir. But there's some connection problem in her laptop, so then she's reconnecting it. It will be connected in next 2 minutes, sir.
Okay.
Yeah. Yes. They are asking to register and join.
Just register and join again.
Yes, doing already, but there is some issues with that. Launch meeting. Launch meeting में चले जाओ ना. Yeah.
Recording in progress.
Started, sir.
You are on slide 6 or slide 5?
Yes, just
Slide 5, I think.
Slide 5. Just go to slide 5 and start from there.
Yes, sir. Sir, is my screen visible?
Yeah, screen is visible. Just need to enlarge and go back.
Yes, sir.
Yeah, okay.
I'm
Okay.
sorry.
Yeah.
I'm sorry, sir, for the interruption. So can I start?
Yeah.
Okay. So primary management was done in the hospital. The baby was admitted to the NICU for further management. Airway support was started. Flow was 6 and FiO2 was 40% in view of respiratory distress. Inotropic support, noradrenaline
Just a
started.
minute. I think you and Snehal are just a minute. Just a minute. I think you and Snehal are in the same room or something. Equal just over.
Okay, sorry, sir.
I'm sorry. Should I leave from here, sir?
I think you can just log off. You can best avoid that.
Hello. Yes, sir.
Yeah.
So primary management was started in the baby. Baby was admitted to the NICU for further management. Airway support was started in view of respiratory distress. Inotropic support, noradrenaline started at 0.1 microgram per kg per minute in view of hypotension, considering septic shock. First shot of IV antibiotic given after sending blood culture. RT insertion was done in view of for stomach decompression. Cold saline wash, tappet sponging, antipyretics were given. The child was kept NBM and there was gradual improvement in tachycardia, fever and perfusion.
Yeah, so just wait. Go back.
Yes, sir.
I just wanted to have an idea. What antibiotics were given considering that the baby had very abscesses, limbs
Yes,
were
sir.
not moving, considering osteomyelitis was possible.
So actually, sir, that was my next slide. Actually, the parents had the documents for the same of outside hospital, and they had done a pus culture report from the swelling, and that was sensitive to methicillin resistant Staphylococcus aureus. And as per the sensitivity pattern, injection meropenem and IV linezolid was started.
Okay. Right. So and blood CS, how much ml of blood CS was sent?
Sir,
What is
around
the criteria for sending?
1 to 3 ml of blood culture is in a PET plus bottle, sir.
Okay. You an X-ray, you show us an X-ray later.
Sir, actually,
You will
the
show us an X-ray
X-ray
later.
X-ray document, we didn't had the X-ray image of the child with us.
Because baby had respiratory distress, you would have taken some
Yeah,
X-ray.
we had done an X-ray. It was reported with mild infiltration. Otherwise, it was normal, sir.
So have you seen, you don't have the X-ray for it, but have you seen the X-ray and can you tell us whether there was...
Yes, sir. Sir, yes, sir. I had seen the
So
X-ray.
there
It
was-
was normal, sir.
So you did not see any pneumonia or anything like that?
This is Snehal here. So it was mild infiltrates only. Otherwise, the lung fields were clear, sir, on X-ray, sir. I'm sorry, we have, not kept the X-ray, which because there was a cyber, attack at KD, and we had, got. We have, lost all the data before. So we were only some of the data we could retrieve. So we lost the X-ray of the patient.
Yeah, that's what.
Some of the X-rays have been lost, but the the repeat X-ray of the patient is there, which will be displayed in the case.
The reason I'm asking is because if the X-ray did not show under infection, etc., elbow support would it be needed, or did it reduce the respiratory distress? Because you said the intercostal retraction. So did elbow support help?
Yes, sir. It helped. The respiratory distress gradually was reduced, and the baby was doing better, and we were able to taper the oxygen in the.
So the ECMO was kept basically in view of serious sepsis and poor perfusion, and to stabilize the ventricles, we have started with an adverse support to the baby, sir, and that was a metabolic acidosis as well. So that will if the ventricular stabilization and the cardiac output would improve, that will help us the good having good hemodynamics of the baby, sir.
Fine. Okay, we'll go next. Thank you. That would help basically reduce the what is metabolic
Yes, sir.
requirement of etc.
Yes, sir. Yes, sir.
Like support is please go next.
Outside investigations in view of abscess, incision and drainage was done at outside hospital, and the investigation was suggestive of MRSA in pus culture, which was taken from the swelling over right and left shoulder, for which aspiration was done. Other investigations were not available with the parents.
So this baby was admitted on 8th and then took Dama and came to hospital. 18th day of life.
Yes, sir.
So when was the pus culture report available, and do you have any idea what?
Yes, sir. It was taken.
Started?
Yes, sir. It was taken on 10th day of life. The baby was admitted there on 8th day. They had started some empirical antibiotics. The documentation of the same was not available. But as soon as the pus culture report came, they had started with IV meropenem and linezolid for the child, and which we continued on receiving the report.
So they had started on 10th or 11th, and then they started on maybe 15th day, 2-3 days after the pus culture was.
Yes, sir. Yes, sir.
So was there any improvement from 15th to 18th day?
No, sir. No, sir. The improvement was not there, and the child was clinically deteriorating. And when we received the child, it was in shock state. So they had took Dama, and they came to our hospital.
So yeah, that's the point. So why did you continue the same antibiotics if they had started the same month? My under question is, if they had a culture report in hand, they had started the appropriate antibiotics.
Sir, because the antibiotic was the investigation was suggestive of MRSA, and linezolid is more or less important for MRSA, and it will show a gradual improvement. Immediate improvement is generally not seen, and if that is a deep-seated abscess, then we need repeated incision and drainage of the abscess, because the antibiotics won't work in the avascular area of the abscess.
All right. Please go ahead. Next.
Yes. So blood investigations were done on day 1. ABG was suggestive of compensated metabolic acidosis. The lactate value was 2.2. The routine blood investigations were suggestive of anemia and thrombocytopenia. CRP was raised. There was altered coagulopathy. PT-APTT both were raised, and INR was 1.59. Other reports, electrolytes, creatines, GPT were within normal limit, and the blood culture was sent. Immediate medical management was started, and fluid resuscitation, maintenance fluid was given. IV antibiotics, injection, meropenem started in anti-meningitic dose, and linezolid as per the culture report. Inotropic support, airway support, 1 PCV transfusion was given in view of low hemoglobin, and supportive care continued. USG local path screening was done in view of multiple swellings, which was suggestive of mixed echogenic irregular collection in the right proximal arm, which extended up to the humerus shaft. It was around 5 into 2.5 into 2 centimeter, 12 cc volume was seen. Similar collection was seen in the medial shaft and sternal end of the clavicle, which was around 6 cc volume, 4 by 2 into 1.5 centimeter. We had also screened for hips, both hip and thigh and gluteal region and legs, but no collection was noted in the same. We did a pediatric surgical reference. Incision and drainage of the abscess was done over the right and the left shoulder. 4 cc and 2 cc pus were drained respectively twice on 22nd and 24th day of life. We had sent the pulse culture, and blood culture was also suggestive of MRSA. The reports are as these. So both the pus culture and the blood culture was suggestive of methicillin-resistant Staphylococcus aureus, and they were both sensitive to linezolid.
So one thing is, was there any lumbar puncture done at any point of time, because it's very anti-meningitic doses? I didn't mention any lumbar puncture.
Yes. Sir, initially there was severe thrombocytopenia, and later we had advised the parents, but they didn't give the consent for the same. So we started empirically at anti-meningitic dose.
So this was sensitive for linezolid and both your pus as well as blood culture.
Yes, sir.
It talks about MIC, right? Minimum inhibitory
Yes, sir.
concentration. Okay, go next.
Yes.
And
MRSA.
you have any idea of MBC? Yeah, MIC है. There is something as MBC.
It is minimal bacterial concentration.
Minimum bactericidal concentration. So what we use for minimum inhibitory, this is bactericidal. When if you use MBC, then you have to give higher doses. Go next.
MRSA protocol was followed, strict isolation, hand hygiene, single staff nurse, and during the stay, the baby developed both thigh swelling gradually by 25th day of life. Repeat USG screening was done. It was suggestive of mixed echogenic collection in relation to the right hip joint, which also extended into the medial thigh in the intermuscular planes. Because there was deep-seated abscess, we to rule out the possibility of bone involvement, MRI screening of both hip with both clavicle and humerus was done. It was suggestive of moderate to gross amount of collection in the right hip with suspicion of periosteal and subtle bone erosion along the proximal femoral shaft. Also, there was mild amount of collection in the left-sided hip joint, where the findings were consistent with infective etiology. Similar findings seen in the right humerus and the left clavicle. Sorry, sir. Hello. Can I continue, sir?
Can you go back because I lost my connection?
Yes, sir. Yes, sir.
I think I was here. That's my question. Okay, please go ahead.
Yes, sir. Pediatric orthopedic reference was done. On 27th day of life, they planned for arthrotomy and debridement in view of multifocal osteomyelitis. Right and left hip arthrotomy, right and left femur osteomyelitis debridement, left clavicle debridement, and right humerus osteomyelitis debridement was done on the 28th day of life. These are the images, images of the baby. The pus was aspirated from the right hip joint. And also in the left hip. This is the video. So this is very surprising that such huge amount of pus was aspirated from the very small joint of the baby.
Yeah, next. Next.
Alternate day dressing was continued. We gave a sling to the shoulder joint to immobilize the joint. Repeated pulse cultures were done, and the last pulse culture was negative, and it was maybe because of sensitive antibiotics. Further course, repeat septic screen were done, which was showing gradual improvement, decreasing CRP and improving platelet count. In view of hypoalbuminemia and edema, albumin transfusion was given. PCV transfusion was also given twice, and one FFP was given. Gradually, inotrope and oxygen support were tapered and stopped. RT feeds were started and stepped up. On reaching full feeds, the baby was given spoon feeding and breastfeeding trial. These are the investigation images. So we can see that there was a gradual increase in the platelet count, and also there was a decrease in the CRP level of the child, and we reached negative CRP by we did an infantogram on day of life 45 to check for the X-ray images. Cortical erosion with periosteal reaction was seen on the entire shaft of the right humerus, mid shaft of the left clavicle and proximal right femur. So here we can see periosteal reaction on the right femur bone, and also here on the right humerus we can see cortical erosion with with periosteal reaction. We continued with IV antibiotics for about 4 weeks, and then the baby was given oral antibiotic for the next 2 weeks, was discharged after 35 days of hospital stay on spoon feeding and breastfeeding. Weight gain was seen, and the weight on discharge was 2.457. Baby was hemodynamically stable. We had given a pelvic harness to restrict the joint mobility and for better healing. The child was followed up every 15 days initially for the first 3 months with neonatologist and pediatric orthopedic surgeon, was followed up 6 monthly later on. The limb movements were good. The child achieved age-appropriate milestones. Now the child is of 1 year, 4 months. She is asymptomatic, thriving well. She can bear weight on both the lower limbs. The right lower limb is short as compared to left. These are the post-op images on the follow-up we did. So we can see here the epiphyseal center of the right femur is not seen. Also, there is mild cortical irregularity. Also here on the right humerus, we cannot see the epiphyseal center. So this is a case series which was done at Chacha Nehru Hospital in New Delhi on neonatal osteomyelitis. They had reported 3 cases, and all these 3 cases, they had almost similar presentations. The child had come with thigh swelling with fever, and in 2 of them we could see MRSA in the pus and the blood culture reports. 1 of them had no growth. And they gave almost 5 to 6 weeks of IV antibiotic plus oral antibiotic. These are the images they had. So neonatal osteomyelitis, it is an infection of the bone and the bone marrow, which is very uncommon. There is a incidence of 1.5 case per 1,000 in ICU admission. Because of decrease in the neonatal sepsis, there is a decreasing incidence. The modes are traumatic, transplacental, local by nearby soft tissue infections, or hematogenous. If it is a hematogenous multifocal osteomyelitis, then it is a dangerous form in which sepsis can develop very quickly, and not treated early, then it may lead fatal to the child. In our case, this was the probable cause. It has a predilection for metaphysis of the long bones due to peculiar vascular anatomy. Latent period is around 1 to 3 weeks. This is the pathogenesis. The transphyseal vessels will help the bacteria cross the physis. It will cause vessel occlusion and leading to ischemia, infarction, and bone marrow hyperplasia. The areas of the bone will become necrotic, and then it will lead to hyperemia with polymorphonuclear cells infiltration, which will lead to increased intraosseous pressure due to the exudates. Further necrosis occurs, and then the exudate will get accumulated in the subperiosteal space to form an abscess. Why metaphysis? Because of the various factors. There is a hairpin bend vessels in the metaphyseal region of the bones. There is an increased vascularity which causes pooling of the blood, immature cells due to high cell turnover. There is a relative lack of phagocytosis. End arteries are seen, and it is very prone for trauma. The most common site is lower limb as compared to the upper limb, and femur and tibia are the most common bones involved. Most common organism is Staph aureus. It is around 90% cases. MRSA is the major pathogen. Presentation generally presents with very vague complaints like feeding difficulties, excessive crying, lethargy, generalized or some localized swelling, decreased limb movement. Some predisposing factors are there: penetrating trauma, invasive procedures like umbilical arterial catheterization or PICC line insertion, skin and soft tissue infection, umbilical sepsis, prematurity. Diagnosis, history and examination are the key points. It is very difficult to diagnose in early stages due to the latent period. There are some paucity of clinical signs, and also on early radiological investigations or routine investigations, the signs are not visible. Investigations, it was positive septic screen, raised CRP, ESR, and total counts, positive blood culture and pus culture. Radiographs in early stage, X-rays won't show much findings. They will only show soft tissue swelling. In the late stages, periosteal elevation, lytic lesions, joint effusions would be seen. USG can also help us to see the soft tissue changes and presence of subperiosteal abscess. But MRI is the gold standard, and earliest signs seen as bone marrow hyperplasia. Diagnostic criteria, there is a Peltola and Vavenance criteria. If 2 of the 4 are found, then it is positive. There is a purulent material on aspiration of the affected bone, positive findings on the bone or blood culture, localized classical findings, bony tenderness, overlying soft tissue edema or erythema, positive radiological imaging. In our case, 3 of the findings were seen. Conservative management is must. Analgesics and appropriate positioning and splinting, supportive measures, medical management, IV plus oral antibiotics remains the mainstay of treatment. Surgical management is required in 50% of the cases.
So, let's wait here and discuss this. You switched to oral therapy after 4 weeks.
Yes, sir.
So, what is the ideal guidelines? Do it for 6 weeks, give for 4 weeks. When to switch to oral? How are these things kind of decided?
Sir, total 6 weeks of therapy is must. They say that as per the clinical and the lab parameters improvement, we can continue for the IV therapy at least for about 2 to 4 weeks, depending on the child's condition. And if the baby is doing better, then we can shift to oral therapy.
So, what do you mean by baby is being better?
So if the septic screen and everything is decreasing and in the negative trend, the hemodynamic vitals are stabilized, then the pus culture and the blood culture reports, if they are turned negative, then we can shift to oral therapy.
Okay, so there are some guidelines that are available. So one of the things is, I think the baby has to be more than 1 month of age, which was in your case. The baby has to be more than 1 month of age. After this, you can switch to oral. As I said, baby is improving as far as clinical is concerned, or his CRP parameters are coming down. There's also another indication which is there, which is mentioned, is baby should be immunized against H influenza and Staphylococcus pneumonia. So that is something which I don't think was done in this case. So that is a common thing which are there. Because there is an issue with continuing IV therapy also. So what oral therapy you started in this patient?
We shifted to oral linezolid, sir.
And for a single dose, or you added anything else?
On oral
Only one
augmentin. On oral augmentin, linezolid.
What was the advantage of giving augmentin rather than giving only linezolid? Because you have culture which shows linezolid. Why was augmentin used? Also, another question was, I think Dr. Urvi asked, you did not show any meropenem sensitivity. We did not see any sensitivity. Meropenem.
Yes, sir. Because the meropenem was not sensitive, we had stopped after 14 days. Once we got the blood culture and the pus culture reports.
Okay, so that is what we wanted to ask. So, please go ahead. On follow-up, so we have done a number function. And so, did you get any further on follow-up? Any sign that meningitis might have occurred or delayed development?
No, the milestones were all appropriate. There was no delayed development. Only there was some shortening of the right upper limb, which was right lower limb, and otherwise the baby was moving all the 4 limbs and bearing weight on both the lower limbs as well. So the baby is doing quite better.
So, what are the causes for osteomyelitis? Not a very common thing. Plus, having osteomyelitis in one place is fine, but osteomyelitis or infection occurring across various joints, what are the other things that you might want to consider? Other diseases which might be there.
If in any immunocompromised state, any immunocompromised state like HIV in the mother, which would be there and inadequately treated. Then neonatal sepsis, it can, if adequate antibiotic therapy is not given within time.
So all these, all the neonatal sepsis, etc. Most of them
No,
end up
sir.
with one or maximum 2 joints having osteomyelitis. I
No,
think
sir.
so many are there. Yeah, please go ahead.
So if the baby is immunocompromised, if the weight, as in our child, the weight was 2.5 kg and the child was not gaining weight and the baby had lost weight initially. So that might be one of the factors. Even we could have worked up for immunodeficiency workup in the
So
child.
that is my question. Did you do a workup for immunodeficiency in this child after the baby improved and improved?
Sir, actually, they live in Abu, so we had planned to do after 6 months, but they had not come for follow-up.
So what would be the most likely immunodeficiency disease that?
Sir, Staphylococcus aureus is generally seen in hyper IgE syndrome.
Okay. All right. So you would want to evaluate for immunodeficiency. Okay. Good. Is there a chance of recurrence in this patient?
Yes, 10 to 30% of cases do relapse.
So there's another question that has been asked. What is Job syndrome?
Hyper IgE syndrome is Job syndrome.
Correct, you mentioned. And chronic granulomatous disease also can be there, which might have, which can have osteoarthritis also. Sickle cell is something which can cause it, but I don't think it would cause such a. We have a lot of sports. Yeah, it usually causes salmonella
Yes.
osteomyelitis. Very correct. Yeah, continue.
So, sequelae to neonatal osteomyelitis, around 10 to 30% cases we see sequelae. Limb length discrepancy is most common, which was seen in our child. Angular deformities, growth plate disturbances, pathological fractures. There is a restricted range of motion and joint dislocations. There was a need for long-term follow-up because these sequelae sometimes take around 8 to 10 years to develop, and as they would have an increased chance as the child will grow. Chronic osteomyelitis is very rare in neonate because they have extensive vascular supply and early resorption of the cortical sequestra, favoring prevention of chronic osteomyelitis.
Right.
So my conclusion is neonatal osteomyelitis is often missed. It requires a very high index of suspicion, especially in late onset sepsis or prolonged septicemia. Sometimes the babies, they do receive prolonged antibiotic treatment for septicemia, but they don't target the root cause. Initial X-rays might not reveal changes, necessitating repeated skeletal surveys based on the neonate's clinical progression. This highlights the need for early diagnosis and treatment by maintaining a high level of suspicion to prevent.
Am I disconnected? Hello?
No, sir, you are audible.
I got disconnected. Okay.
Thank you.
Thank you, Dr. Viraj, for presenting in detail. Very interesting case, and also quite a lot of questions from participants. It's very interesting. I've seen very few neonatal osteomyelitis cases. Most of them are usually secondary to intensive care for a long period of time. But this particular child did not receive that, and so I think it will be very important that this child continue to have immunodeficiency evaluation because we do not know. It might be there and it might come up again later in the specific period of time. So that would definitely be important. Can you stop sharing? So,
yes, sir.
Sir, I'm here. Sir, the patient is coming right now. The patient is 1 year with a follow-up with me and otherwise doing well. You are right, sir. There should be a suspicion of an primary immunodeficiency in this child. I had just got an immunoglobulin level done initially, but then the CD counts and T cell immunity level workup has not been done. So we'll consider it.
It would be good to kind of that is done. At least because sometimes they might have an infection later on in life, and then again you go searching for a diagnosis. Better to have details early on. Be well. So very uncommon for a baby to have so many abscesses at a particular point of time.
Right, sir. Right.
So another thing is you'll have sometimes with electrosimia can cause osteomyelitis. So hidden sepsis or sepsis. Most of the patients that we get osteomyelitis are basically babies who are remained in ICU, who had got sepsis, got discharged, sepsis was not discovered, and one nidus ends up in the bone, and babies come at 2-3 months later on with sepsis. So that is the more common reason. This one actually is presented in the first week itself. 8:30 they presented. So this is pretty early. Okay. Nice. So if any other questions are there, we can discuss them. Are there any specific parameters or which can differentiate that the baby has osteomyelitis early? You said they miss and they present late. Is there any way we can pick up osteomyelitis early?
Because it is very because the presentation is very vague, so there should be very high index of suspicion in all the cases of neonatal sepsis. So clinical examination is the first. Every time we look for the child, we have to look for any developing swelling or tenderness over the joints or the bones. And if there's a child with excessive crying, it should be examined thoroughly.
It's actually, I think no lab parameter will definitely be an indication. It's basically when you have clinical examination shows that there is less movement of an ileum.
Yes.
That will probably give you an early indication. And as I said, even if you do an initial X-rays, you might not pick it.
Yes.
It's very difficult to zero in on that till it becomes very obvious. So that's something which is not so common. So if this jaundice happened, do you think it had anything to play? Because jaundice set, I think 48 hours. Day 3 of life, day 4.
The jaundice would have led to might have been because of the weight loss or dehydration, and that had led to the hospital admission, which would have caused hospital acquired infection in the baby. Also, sampling might have been done for the same. So if in a proper aseptic technique would have not been used, then there is a chance of introducing an infection in the baby.
So long back, not now, before all drug tests, etc. were available, people used to use scalpel and many times used to puncture the femoral vein, and if it was done improperly, it is resulting osteomyelitis of the femur and the hip infection there. So that was one of the common cause way beyond maybe 30-40 years ago. No longer the case now. But I don't think it would be very. So one is having MRSA was surprising in this particular patient, and very difficult to blame hospital-acquired infection for that. Because when baby came at 8:30 or would have presented with swelling on 6 or 7:30, it already had infection. So it's typically late onset sepsis. Is it possible that mother might have an infection? Was there any history of mother having fever during delivery time or around that period?
No,
Was
sir.
there any intervention done?
No, sir. I asked for the questions to the mother for any delivery during labor room or any before delivery there was any fever or anything, but there was no positive history from the mother.
So why do you think the baby survived or baby managed to recover from osteomyelitis?
Along with IV antibiotics, which was sensitive, we also did a surgical intervention, which was done early. And removing the pus and debridement of the necrotic portion is more important because IV antibiotics won't work in that area. So both the factors helped.
Yeah, so I think what did not happen in Abu or in the previous hospital was debridement or discharge of the removal of the pus. That has probably helped the baby fight off the infection. So you are right. Surgical intervention was absolutely essential in this case to ensure that the baby improves. Yes. So coming because you use linezolid, so tell me something about linezolid. IV or oral में bioavailability का क्या? What is the difference between bioavailability and linezolid?
Sir, it's same.
Very good. It's the same. So actually, linezolid is a very good drug for us. When you shift from IV to oral, you actually don't lose anything in such cases. Yeah, good. Thank you. You can name any other drug which is similar bioavailability, IV or oral.
Paracetamol.
Not so much, but yes, all right. We found the same from. Okay. I think it's been excellent. I think you can close the session because we've reached 4 o'clock. We started on time and we promised to end on time. So back to you, Urvi.
Thank you, sir.
Thank you, Dr. Vishal and Dr. Urvi for asking questions.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Shweta.
Thank you, sir, for such a expert and lucid and detailed discussion for solving many queries and highlighting many clinical points as well as treatment wise. Thank you, Dr. Viraj. It was an excellent presentation and very nicely managed, timely intervened, and the baby got well. So I hand over to Dr. Kunal.
Yeah, I think I must appreciate Dr. Snehal for supporting Dr. Viraj and tracking the baby for 1.5 hours. Normally, whatever patients we get, we present are usually presented in last 1.5 hours. Good.
Thank you, sir. Thank you, sir. Thank you so much, sir.
Thank you, Dr. Viraj, for the excellent presentation. It was a very well managed case, and of course, Snehal had been your mentor, and so it was a very nice work monitoring by Dr. Snehal also. Thank you, Somsekhar sir, for the excellently asking all the brilliant questions and taking through the session very nicely. Thank you so much, sir. Thank you, Dr. Urvi, for excellently moderating this session. Thank you, ClearNet, Shreyasi, for giving us a seamless experience. Thank you all, and thank you for the participants who are all there till the end. Thank you all. Thank you, Dr. Vishal and Dr. Urvi, for asking the questions, and Dr. Vijay for being there till the end. So I thank you all. And Shreyasi, now we can conclude with the session. Thank you.
All right, then. Bye. Bye.
Okay.
Bye.
Bye, sir. Bye.
Bye, sir.
Bye.
Thanks a lot.
Thank you.
Thank you.
Thank you, sir. Shreyasi, we can stop this session now.
Sorry.
Oh,
Shreyasi? Shreyasi, are you there or? Request everyone to exit so that the meeting ends. Thank you all.